The treatment for eclampsia is the delivery. And again, we all have the doubt, can we do the induction or can we do the cesarean delivery for the eclamptic mother? If the mother is stable and if the cervix is favorable, if she is more than 32, 34 weeks of gestation, you can try with the induction of labor. If the mother is not so stable and if cervix is not favorable, then go ahead with the cesarean delivery. So this is the checklist that we follow for the eclampsia. And the postpartum hemorrhage, I think day in, day out, I think we all face this. And primary postpartum hemorrhage is if the bleeding occurs within first 24 hours, and the secondary is from the 24 hours to the 12 weeks postpartum. And the etiology is mainly atony, and it could be the retained products, or it could be the trauma, or it could be the thrombin, that is consumptive coagulopathy. So the risk factors could be like prolonged labor and cesarean delivery, episiotomy. So this is how we have to deal with the major obstetric hemorrhage. So whenever there is a hemorrhage, call for help, and you have to alert the hematologist, and you have to alert the blood bank. This is very important. And you have to work your way with securing the airway, breathing, circulation, and you have to means all these tasks should happen simultaneously. You have to get 2 large IV bore cannulas and get the bloods for the cross matching and LFTs, and to check for the coagulation profile and FPC. And while we are doing that, at the same time, another team member should be engaged with giving the medical management. So rub up the contraction. If there is no response, give oxytocin 5 units IV. That's we give for the patients who are having the cesarean section slowly. And if the woman is having the normal delivery, most of the time we give 10 units IM. And if she is not responding, then you can move on to the carboprust, 250 micrograms once in every 15 minutes. You can give maximum up to 8 doses. And the next drug of choice is the methergine and misoprostol, and tranexamic acid is one of the best drugs that help to control the bleeding. Suppose if the bleeding is still not getting controlled, then it's a time for us to move the patient to the theater. Again, once we reach the theater, we all have the tendency to go for laparotomy, do Bielen's suture. But before that, think of a simple thing, that is the balloon tamponade with the Bakri balloon. So this Bakri balloon we can insert through the cervical canal into the uterus and inflate it up to 300 to 500 ml. And usually, most of the time, 80 to 90% of the PPHs can be controlled with the Bakri balloon. And you can remove it 4 to 6 hours once the mother, after the mother stabilized. And the Bielen suture, I think most of you are aware. And we are blessed at our unit to have uterine artery embolization. So obviously, if none of the methods work, you can go for uterine artery embolization. And it's being the quaternary referral center, we do get the patients who had hysterectomies outside and still having the PPH to be treated here. Most of them respond with uterine artery embolization. We did had our own cases with the HELP syndrome having PPHs. In that case, actually they were bleeding from inferior epigastric vessels because of the HELP syndrome and coagulation profile disorder. And even by embolizing inferior epigastric vessels also, the bleeding was controlled and mothers were saved. And I think all of us remember this great obstetrician, Dr. Archana Sharma, and she actually dealt with the PPH in her district general hospital, in her own hospital, and she did her best to give best to the patient. Unfortunately, the mother died, and they filed the case against Dr. Archana, and she couldn't take that stress, and she committed the suicide. And I would like to urge all of you, we all go through these stressful situations. Please, please do not take these kind of steps, and we have to support each other, and just we have to give the time, things will settle. And obviously, you think before you do anything, it's like the patient get many doctors, but your children, and you have only one mother, that's you, and your parents have only one daughter, it's you. Your husband have only one wife, it's you. So don't do these kind of things, be brave. And this is the checklist we follow for the PPH. And antepartum hemorrhage, more or less, I think we are running late with the time, so it is managed in a similar way as PPH. And the amniotic fluid embolism, again, this is one of the rare things. Sometimes we face this situation where there is a communication between the amniotic cavity and maternal circulation, and the amniotic fluid enter into the maternal circulation, and it triggers systemic inflammatory response. And in the first hour, there is typically pulmonary hypertension, followed by right heart failure, and then followed by left heart failure, and then they will have hypotension and hypoxemia, which will trigger multi-organ failure. And there could be concurrent activation of coagulation cascade, which can lead to DIC. So the management is, first treat the hypertension with the vasopressors, and you have to give the respiratory support and blood and blood products. If the woman is not delivered, then deliver the woman. This is the checklist we follow. So the conclusion of my talk is the obstetrics is associated with complex procedures, and whenever there is complex procedures, there is the human error that can happen. And if you look at the airline industry, they have less number of accidents compared to the road traffic accidents. So why do you have the less accidents is we have the checklist at every point. So because in the obstetrics, some things are not under our control, and we cannot avoid this like PPH and all. So it's very important that you have a checklist on your labor ward and work through that. Thank you.